Hello and welcome to the Kampala Advanced Trauma Care course by Yale Department of Surgery, UCSF Department of Surgery, the Lowercase Trust, Global Partners in Anesthesia and Surgery, and Mulago National Referral Hospital. I'm Dr. Kathy Chidiwala from Makerere University Department of Surgery, and I'm going to take us through burns. We shall go through the epidemiology of burns, the initial assessment of an acutely burnt patient, management strategies in the care of burn patients, adaptations for the resource-limited settings in the care of burn patients, and we shall also discuss a burn case at the end. In the epidemiology of burns, 90% of the global burn burden is in the low and middle-income countries. Globally, 180,000 patients die from burns alone per year. The likelihood of this occurrence is 7 times higher in the low and middle-income countries compared to the developed countries. It is important to note that burns are a preventable cause of trauma. What the developed countries have in place compared to the low and middle-income countries are implemented preventive strategies against fire and burn occurrences. These strategies range from mass education on prevention of fires and burns, policies for prevention of fires and burns, and I'll give an example. For indoor fires, for all commercial and non-commercial buildings, there are few policies in place to ensure that in the occurrence of fires, people will not suffer burns. And these range from having fire extinguishers in commercial and non-commercial buildings, having clear exit holes for evacuation in case of a fire outbreak in a building, fire and smoke detectors in buildings that are alarm sensitive for people to immediately evacuate in case of fire sparks, very vigilant first responders in case of a fire outbreak. These responders are also what we would call the fire brigade. Now, these are implemented in the developed countries and are still wanting in the low and middle income countries. Who is at risk for burns? In the low and middle income countries, women are more at risk, mainly because women are exposed to fireplaces in attempts to cook compared to men. But peculiar to this is the nature of the cooking areas we have in the low and middle income countries compared to the developed countries. We have open fires, things like using firewood, charcoal stoves, which put women at higher risk for burns compared to the cooking areas in developed countries. The next category of people that have high risk for incurring burn injuries are the children. One, because we have a high percentage of children that stay at home and are not in school. Two, these children may be at home unsupervised and performing adult chores like cooking, so they also tend to be at high risk. The other category of people in the low and middle income countries that are at risk of burns are the adults, especially when they are living alone, drunkards, and people with disability. And in this category, I want to pay attention to people with conditions like epilepsy. We will now talk about the management and assessment for burn patients. The assessment for burn patients does not differ from the trauma assessment that you have already gone through. It follows the ATLS protocol, where one will do the primary survey and the secondary survey. The primary survey is also known as the initial assessment, and it follows the ATLS protocol as earlier said. We look at the airway, the breathing of the patient circulation, we look out for neurological disabilities, and we expose the patient. Specific to burns, for the airway, we are worried about any threats to the airway caused by inhalation or injuries. We also make sure that we expose the patient, one, to stop the burn process, and also to assess the patient. However, the exposure should be well controlled, as you know that following burns, you lose the integrity of the skin, which is a very important thermoregulatory organ. So when you're doing the exposure, you have to be aware of the possibility of causing hypothermia to these patients. So it has to be very controlled exposure. After the primary survey, we do the secondary survey. And in the secondary survey, as is in the ATLS protocol, for burns, you're also interested in determining the site of the burns, the size of the burns in terms of percentage body surface area that has been burnt, determine the severity of the burns in terms of the depth or the degree of the burns, and we'll go through those. And then in the secondary survey, you want to ensure pain control. And if in your primary survey you didn't have IV access, or if you struggled, you'll go back to revise that you have IV access. Under airway assessment, you are going to look out for telltale signs for inhalational injury in these burn patients. Some of these signs include burns to the face or the neck, singed nasal hairs, carbonaceous sputum, a hoarse voice, or swelling of the upper airway. Upon visualizing these signs, make a decision to intubate these patients earlier before it becomes difficult as the swelling progresses. If intubation becomes difficult, these patients can also benefit from high-dose steroids, using steroids like dexamethasone intravenously or hydrocortisone. In your assessment for breathing, you want to expose the patient and ensure the patient is breathing adequately in terms of adequate chest expansion bilaterally. Also note the respiratory rate of the patient and how regular their breathing is. So you want to see if this patient is tachypnic and if they have any features of respiratory distress. And in case they have any of these features, don't hold back on giving them supplemental oxygen in the form of nasal prongs or using a face mask. If you notice that the patient has inadequate chest expansion and is also having circumferential burns to the chest wall, especially third-degree burns, these patients have formed an eschar across the circumference of the chest wall, and they'll benefit from escharotomy. In circulation, 1. You'll control any external bleeding in case the patient comes in with burns and an overt source of bleeding. Establish IV access. It can be peripheral IV access or central lines. And in some circumstances, you might have difficulties establishing IV access. For example, if a patient has burns in areas that you'd usually find your IV access. So this sometimes will call for central line placement or venous cut down as one of the procedures that you'll be able to perform during care for a burns patient. In the fluid resuscitation for burns patients, we prefer starting with crystalloids, and the commonly used formula among the many formulae that you might have to read about later is a Parkland formula. So the fluid of choice is usually Ringer's lactate, but if it's not available, you could also use normal saline for the patients. And using the Parkland formula, you'll give 4 cc's of this crystalloid fluid you've chosen per kilogram body weight per percentage body surface area burnt. This volume is given in 2 bits. The first half of the volume you calculate is going to be on the patient in the first 8 hours, and the second half of the volume you calculated will be given the patient in the remaining 16 hours from the time of injury. So in disability, we want to see the neurological status of the patient. According to the ATLS protocol, we talk about the AVPU assessment to assess if the patient is alert or responsive to verbal communication or responsive to pain or unresponsive. The other assessment you can do for neurological status is a Glasgow Coma score, where you want to go through the 3 components of the GCS scale. For E, you expose the patient, removing all the clothing the patient has on. It could be charred clothing that is continuously burning the patients. It could be products of combustion that are irritating the skin. So you want to remove this from the patient and stop the burning process. Control the environment the patient is in terms of the temperatures. That is, if you're capable of increasing the room temperature, that will be very okay to prevent hypothermia. Like I mentioned earlier, when there is injury to the skin, there is compromise to thermoregulation, and these patients will suffer from hypothermia. Once the patient is exposed, take this opportunity to estimate the total body surface area that has been burnt. Remember that you're going to use this percentage in calculating the fluid requirement for the patient during resuscitation, and also document the severity of burns. For estimating the total body surface area that has been burnt, there's very many methods that can be used. One is the Lund-Broder chart. 2 is the rule of 7 in children. 3 is the rule of 9 in adults. 4, there's a palm rule, among many different methods. So here I show you the Lund-Broder chart. What this chart has is an estimated percentage that can occur in case an area is burnt entirely. For example, if a child's face is entirely burnt, it will contribute 7% to the total body surface area that has been burnt. If it were an adult's face that has been burnt, it will contribute 4.5% to the total body surface area. So following the different areas or sites of the burns, this chart shows you what percentage the total body surface area will be in terms of burns. And with this calculation, one would know the severity of burns in terms of total body surface area that has been injured. As I had mentioned earlier in our fluid resuscitation plan, we use very many different formulae for resuscitating these patients, and one of them is a Parkland formula. Here we use a crystalloid, preferably Ringer's lactate, and if we do not have Ringer's lactate, we can use normal saline. We give 4 mL per kilogram body weight per total body surface area that has been burnt. Half of this volume is given in the first 8 hours from the time of injury. The other half is given in the next 16 hours. So this formula is given within 24 hours from the time of injury. Now note that in the low middle income countries, patients might not necessarily come to the hospital immediately after injury, and the pre-hospital care is not very understood. So in such circumstances, your fluid resuscitation will cease to be a mere science, but become an art. So you will have to treat the patient depending on the deficits and what their vitals appear as, to include management of these patients as if were shock patients, if they come in more than 24 hours from the time of injury. Next, we'll talk about the degrees or the depth of burns. These are classified into first degree, second degree, either superficial partial thickness or deep partial thickness second degree burns, and then lastly, the third degree burns, which are the full thickness. Why we like to discuss the depth of the burns is because, one, the deeper the burns, or with differences in the depth of the burns, it gives us the severity of these burn wounds. That's one. Two, it tells us how long it could potentially take for these burns to heal. Three, it gives us what the potential cosmetic outcomes for these burn wounds would be. And four, it tells us what surgical interventions or non-surgical interventions that we may need to put in place to ensure that these wounds heal adequately. So the first degree burns are also known as the superficial burns. They only involve the epidermis, and they are characterized by reddening of the skin. There is tenderness when you touch the burns, and they tend to be warm. So they exhibit all features of inflammation, that is, reddening, tenderness, warmth, and change of color. They also tend to blanch under pressure. So when you're palpating these burns, the reddened areas tend to become white during when you press upon them, and then that they turn back to red. An example of superficial burns are the sunburns, and usually when we are estimating the total body surface area that is burnt, we do not include first-degree burns in that estimation. The second category is the second-degree burns. These are also known as the partial thickness burns. They are further subdivided into superficial partial thickness if they involve only the outer layer of the dermis, or the deep partial thickness burns if they involve the deeper layers of the dermis. In others, second-degree burns extend from the epidermis to the dermis but don't go beyond the dermis. The injury in the second-degree burns is not enough to interfere with the regeneration of the epithelium. Second-degree burns appear moist and shiny or salmon pink. They are usually painful because the nerve endings are intact. They may or may not blister, and they usually heal in 7 to 21 days. So the last category is the third-degree burns, which are also known as the full-thickness burns. These involve the epidermis, the dermis, and the subcutaneous fat. They usually appear thick and dry or pearly gray. They are painless because there is destruction of the nerve endings, but in some patients they could be painful. And whenever you think that the patient feels pain, it's because burns can also be mixed thickness burns. So if there's areas of second-degree burns where the nerve endings have not been destroyed, these patients will feel pain as you try to dress or examine or manipulate the burn patient. There might be minor bleeding because of the depth of the burns, and these burns take really long to heal if you leave them to heal on their own. So there's a requirement for early skin grafting in these patients. So burns do evolve in their depth within 3 to 5 days from injury. So a second-degree burn can evolve to a third-degree burn or a first-degree burn. This usually is encouraged by the level of resuscitation you give the patient. So if the patient is poorly resuscitated, a second-degree burn can advance to a third-degree burn, and a first-degree burn can worsen to a second-degree burn. Another thing that can make a burn evolve or worsen is things like infection. So in a hospital where excision or grafting cannot be performed, the primary goal is to facilitate healing of the partial thickness burns. When to transport a burn patient. Transportation of burn patients to hospital differs from hospital to hospital. Some of the things that are looked at for transportation or admission of burn patients include the total body surface area burnt, which is more than 15% in adults or 10% in children, as these levels of burns may necessitate IV fluid resuscitation, which cannot be done at home. Other indicators for admission include the age of the patient, the site of the burns, comorbidities, for example, I mentioned epileptics, or related injuries with the burns. In the emergency room, patients are only admitted or kept here for purposes of resuscitation, but not prolonged treatment. So after they have been fully resuscitated, you should ably transfer them to either the burns unit or the ICU or HDU, depending on the severity of their burns. But before they're transferred to these areas of prolonged treatment, you have to ensure that their primary and secondary survey have been thoroughly performed. So let's go through the operative interventions that we can do for burn patients. 1. For the airway, intubation. So mainly for patients who have suffered inhalational injuries, we'll require to intubate these patients. So you have to evaluate possible airway burns with optical bronchoscopy. It can be direct or indirect bronchoscopy. The second category of patients that may also need intubation are comatose patients from maybe carbon monoxide poisoning. In case you have tried the non-invasive airway management or oxygen supplementation, you might resort to intubation if the patient is comatose from carbon monoxide poisoning. Another intervention is access of peripheral lines or central lines. So, cannulation or central line placement. And in the access of these lines, you might also have to do venous cut down. Another intervention is insertion of a Foley's catheter to monitor urine output during resuscitation. Another intervention is debridement of burn wounds. So during your burn wound assessment, you might find necrotic areas, you might find, all sorts of things on the burns. So debridement is another process that you do, plus wound dressing. For patients who have suffered third-degree burns, we mentioned that they'll form an eschar, which is a hard, inelastic band that forms, and especially if it has formed circumferentially, your concern is compartment syndrome or difficulty in breathing if this compartment is the chest. So escharotomy is another procedure that can be done. This procedure tends to be bloody, so there's significant blood loss, and in some patients, you may be pushed to transfuse these patients following your escharotomy. So you will plan to have your blood group and cross-matched for the patients to be transfused. The other procedure is giving topical antibiotics and wound dressing for burn patients. This image here shows an escharotomy performed on the chest wall for circumferential burns to the chest. It also shows you an escharotomy on the side for burns to the upper limbs or the lower limbs. So basically, you will make incisions to the depth of the eschar and along the entire length of the eschar to free up that inelastic band that is constricting the compartment over which it exists. In the management of burns, we also want to take care of the nutrition of the patient. Burn patients are usually in a hypermetabolic state. Their metabolism will increase by about 60 to 100% above the normal metabolic rate. So you want to assist that they might not get nutritional imbalances. In some patients, you might be required to put a feeding tube, either a nasogastric tube or orogastric tube, to support nutrition for the patients, especially for children with burns of more than 20% body surface area injured. The aim during nutritional rehabilitation is 7 grams per kilogram of carbohydrates and 2 grams per kilogram body weight for protein. And the readily available sources include beans, eggs, milk, meat, or poultry, and peanut butter. We also encourage homemade tube feed formulas in the resource-limited settings. So things like blending local solid feeds and passing them through the tube. Use of broths or soups from cooked meat or cooked beans or peas and vegetables. Let's talk about electric burns. These occur when a patient is exposed to an electric current. The severity of injury in electric burns depends on the type of current, the voltage of the current, the duration of exposure to this current, and the medium through which this current has been transported to the patient. In the assessment, we still follow the ATLS protocol, that is a primary and secondary survey. We assess their airway, their breathing, their circulation, any neurological disabilities, and exposure. For electrical burns, it's important to examine for hidden injuries. So we'll do cardiac monitoring because most of these patients are in a state of hyperkalemia. We want to assess that they do not have any overt deficits on their ECG and echo. We'll do fluid replacement for these patients. Electric burns cause massive fluid shifts and extensive tissue damage and acidosis. So we give aggressive fluid management in these patients. We catheterize these electric burn patients and monitor their urine output. If the patient has no myoglobinuria, We'll resuscitate them with 0.5 cc's per kilogram body weight per hour. And if they have myoglobinuria, we'll give them more than 1 cc per kilogram body weight per hour. And then if they only have the superficial burns, we'll resuscitate them according to the Parkland formula. So there's challenges related to electric burns. One, it is difficult to assess the extent or the volume of tissue damage following electric burns. Two, the pattern of injury is also unpredictable. So when the electric current goes through the entire body, different organs are injured, and it is not overt from the beginning which part of the body or which organ is injured. So as you go through the management and monitoring these patients, some of these injuries get revealed progressively. Patients who have suffered electrical burns tend to have an increased requirement for fluid replacement. This could go up to 2 to 3 times the Parkland formula that we prescribe for thermal burns. Electrical burn patients also suffer myoglobinuria, which is managed by 1. Giving IV fluids, introducing sodium bicarbonate 1 to 2 milliequivalents per kilogram body weight. You might want to introduce mannitol also, so you give IV mannitol 1 gram per kilogram body weight, plus or minus acetazolamide. Your target fluid output or urine output should be 2 to 3 mL per kilogram body weight per hour, and a pH of urine of greater than 6.5. So the surgical therapy that can be implemented in burn patients includes initial debridement. You want to do early reconstruction for better cosmetic outcomes in these burn patients. Remember that there is extensive tissue damage, so in different compartments you might have compartment syndromes, and fasciotomy should be aggressive and immediately done in case you suspect that you have a compartment syndrome. And in your early reconstruction, we advocate for early skin coverage using either skin grafts or local regional flaps. In some patients, if fasciotomy was not done early, they might have to be amputated early on. So in chemical burns, we talk about acid or alkali burns. If it's acid burns, the mechanism of injury is a denaturation of proteins, hence causing a coagulative necrosis, and what eschar you form is due to formation of the coagulum. And if they're alkali burns, the cause is denaturation of the proteins, but also the fat. That is, the fat undergoes saponification, causing liquefaction or liquefactive necrosis. The severity of chemical burns depends on the nature of the agent that has been exposed to, the duration of contact to this agent, the volume of the substance that the patient has been exposed to, and the physical form of this agent, whether it's powder or liquid. So in the management of the chemical burn patients, 1, you want to irrigate the area, but then limit your irrigation to that specifically burnt area, meaning that as you irrigate the area and you're having some of the fluid flowing off onto the non-damaged areas, you will also increase or spread the chemical injury to these non-affected areas. What irrigant do we use? Water is the irrigant we use. 2, remove contaminated clothing or anything else that is in contact with the patient to control for sustained exposure to the chemical. These patients require emergency medical care, and we still observe the ATLS protocol looking at the ABC, D, and E. You want to completely remove the offending substances, thoroughly irrigate with tap water at low pressure, and after that, you'll manage these burn patients, these chemical patients as burn patients. So in case the exposed area is, say, the eyes, you will still irrigate with tap water at low pressure, and you're aiming at a pH of about 7.4. How to determine that you've achieved this pH is after irrigating every time with approximately 2 liters over 30 to 60 minutes, you'll reassess the pH. And if these chemicals have actually been ingested, you want to avoid gastric emptying. You want to avoid activated charcoal. You want to also avoid the dilution with water or milk. So simply admit the patient, observe the ABCDE, give the patient analgesics, fluid resuscitation, and perform endoscopy urgently to assess for the extent of the burns. So we said we'll talk about the adaptations in the resource-limited setting. What do we do when we have burn patients in the resource-limited setting? For resuscitation, many are times that you have restrictions to what fluids you can access in the resource-limited settings. So as we say, the fluid of choice is Ringer's lactate. If it's not available, kindly use normal saline as your fluid of choice. Albumin might be used, but it's expensive and not readily available in the resource-limited settings. So only if it's available would you use it after your initial assessment. But if it's not available, you do not have to dwell on it. For resuscitation of burns more than 20%, you can also use oral rehydration salts. And this can also be made at home. That is, in 1 liter of boiled water, which we'll call clean water in this case, you add 1 tablespoon of salt, 2 tablespoons of sugar, and you mix. So you give the patient to drink that 1 liter, sipping slowly every 5 minutes. This very same solution can be given via a nasogastric tube if the patient cannot take it naturally. This is very common in children. Many are times that you might not be able to get IV access in patients who have been severely burnt. So this solution is good because it is administered orally, and it's going to help you resuscitate the patient if you cannot yet get IV access. In the resource-limited setting, also we have some adjustments we can make in as far as wound care is concerned. Ideally, for wound care for burn patients, we encourage closed layered dressing. So in our setting, if we have silver sulfadiazine cream applied as a single layer directly onto the burns, covered up with a layer of Vaseline gauze being a non-adherent type of dressing, and this can also be prepared locally using plain petroleum jelly and sterile gauzes, and then a third layer being iodine soaked gauze, and this iodine soaked gauze is prepared in at least 2 to 3 layers. So this is layered on top of the Vaseline gauze. So this layer usually is supposed to be an antiseptic medium. The third layer is a saline soaked gauze, also 2 to 3 layers, and this is supposed to be an absorbent medium. You can also put a gauze pad as your absorbent medium or layer of dressing, and this can be wrapped around the wound for a thickness of 3 to 5 centimeters. And for occlusion, you apply crepe bandage to hold these layers of dressings in place. As you apply your dressings, make sure that the fingers and the toes are dressed separately in a functional position. Why we dress them separately is to avoid synechia or fusion of these digits while they heal. Provide adequate analgesia while dressing all these patients, because the process of dressing or even just changing the dressings can be painful. In the resource-limited setting, you might Encounter patients with inhalational bands, but you have no resources to ventilate. Either you don't have endotracheal tubes, or upon inserting an endotracheal tube, you do not have a ventilator for the patient. That means you don't want to put an ETT in this patient. So you will nurse this patient in a cardiac bed. In other words, elevate the head of the bed in which the patient is being nursed. Control for edema using high-dose steroids like dexamethasone or hydrocortisone in high doses. Don't hold back on giving supplementary oxygen via nasal prongs or face masks. Control the patient's pain, which will also help anxiolyze the patient. Resuscitate the patient, as we've been talking earlier, using the ABCD and EASE. Consider early tracheostomy if you cannot put an endotracheal tube for these patients. So what are the preventive strategies we can put in place in the low and middle income countries? 1. Improving our cooking environments. So if we could adopt to solar or electrical gadgets for cooking, that would be a strategy. School programs. This is mainly for children who are staying back at home in numbers and being exposed to these unfriendly environments. 3. Burn education for homes. This is in prevention of burns. And 2, what care should be given when people encounter burns. And the last strategy would be electricity and gas safety education in our setting. At this point, I want to think we are ready for a case discussion for a burn patient. So if I had a 28-year-old female who has been burnt to the face, neck, chest, and upper extremities after being caught in a cooking fire. As far as assessment of their airway, I noticed that they have singed nasal hair and swollen lips. When I assessed the breathing, she seemed to be having chest tightness. For her circulation, she had a tachycardia. She could move all her extremities but could not feel her fingertips. And when I exposed her and examined her environment, she had clothing adherent to her skin around the chest. My question is, how would you manage this patient? So the summary of management of this patient, we are going to follow the ATLS protocol by performing a primary survey for this patient and a secondary survey for this patient. In the primary survey, we're going to follow the ABCD and EASE. For the airway with the singed nasal hairs, these are telltale signs of inhalational injury. So we'll make a decision to intubate this patient very early. We'll also give this patient IV steroids in the form of either dexamethasone or hydrocortisone, and nurse this patient in a cardiac bed or elevate the head of the bed in which the patient is being nursed. For breathing, as it is mentioned that she has chest tightness, if she indeed has circumferential burns to the chest wall, we'll do an escharotomy. Note that it has also been mentioned that they seem to be not feeling their tips of the digits, which is a sign of a compartment syndrome. So this escharotomy might also be extended to the upper and lower limbs. In circulation, as they have a tachycardia, we'll give IV fluids, initially crystalloids, using the Parkland formula. She seems not to be having any neurological disabilities as she can move all her limbs normally. It would have been good to know what her GCS was. So they mentioned that she still has some clothes on. So in our exposure, we'll take off all her clothes, 1, to control the burn process, and 2, to assess for the total body surface area that has been injured. And then we'll give wound care, 1, by debriding her, 2, I mentioned the sclerotomies, 3, we can give the antibiotics, and also close dressing. And if it is possible for us to do early skin grafting for her, we would do early skin grafting within the first 1 week. If they need any more interventions like rotation of flaps, that will also be catered for to manage this patient. I want to acknowledge the contribution of the collaborators, including Dr. Peter Mwanguzi, Martha Namuga, Sarah Ulrich, Maya Cheng, Michael D. Wayne, Elobo Emmanuel, Keba Naomi, Michael Lipnick, Doruk Ozgedis, Kathy Chiriwala myself, and Christine Namatovu. Thank you very much for listening.